begin. Hi, Dr. Vinny.
Hi, Helen.
Hi, Winnie. How are you?
I'm good. How are you?
I'm fine, thank you.
Good to see you again.
Good to see you again, too.
Looking forward to our session.
Yeah, we're just about to start in a minute.
Yes, let's give people actually we are there.
Okay. Good evening, everyone. On the session. My name is Njoki Washira, and I welcome you to this 10th session of the COGS tele-mentoring series on strengthening obstetrics and gynecology care for maternity teams. Yeah, so I'm sorry, my topic is newborn care, neonatal resuscitation. Equalize Health is partnering with COGS to bring you this online training series. We have implemented this series all over in India and in Africa. So just to start with a bit of housekeeping, please keep yourself muted unless you're talking, and then keep your videos on if possible. Please respond to questions without any hesitation, and you can also post any questions you have on the chat box. So at this juncture, I'd like to welcome Dr. Winnie to introduce the speaker for today.
Okay, thank you, Njoki, and good evening, everyone. As usual, it's a pleasure to have you all here, and we are looking forward to the topic of this evening. The topic is on routine newborn care, neonatal resuscitation, and the common complications of the newborn. So as maternity teams, we rarely get to have the experts talk to us about the neonates, yet we are the people who handle them first. So it's our pleasure this evening to have Dr. Hellen Githaiga to take us through the topic. And Dr. Hellen Githaiga is a pediatrician at Maragua Sub-County Hospital. She has a master's degree in pediatrics and child health, and she has publications, 7 years experience working in the public health space within particular interest in the effect of undernutrition on mental health status of children. So welcome, Dr. Hellen. We look forward to hearing from you.
Okay, thank you so much, Dr. Winnie, for that lovely introduction. And because the presentation is quite long, I'm just going to proceed with the presentation. So if I can share my slides. You can share my slides, please.
Yeah, you will be able to see a green button on share.
Thank you for that. All right, so we can kick this off. So our presentation today is going to be on neonatal care. And it's quite a large topic because we're going to be dealing first with newborn care, then we're going to deal with neonatal resuscitation, and then before we proceed to common complications of the newborn. So the objectives for the first part of the presentation is that we're going to review the neonatal standards of care. We're going to outline the optimum approach to newborn resuscitation, to present global best practice guidelines, and to review the signs of severe illness in newborns. So I'd like to say these are not new things that we're going to learn today. We're just going to emphasize and reiterate on the best practice when it comes to care of newborns. So why is it important for us to take care of our newborns? The biggest issue is because we want to reduce neonatal mortality rates. We have had significant strides in the reduction in our infant and child mortality rate, but our newborns are still dying. And they're dying because of things that we can actually prevent. They're preventable causes. And these are simple things that we can implement to prevent deaths within the first 28 days. So it's good to note that we want to achieve a mortality rate, a neonatal mortality rate of less than 12 newborns per 1,000 live births by 2030. Currently, we are at 21 per 1,000 live births, and this actually is the one which is it's impacting significantly on our infant and child mortality rates. So we're going to go straight up to the neonatal standards of care. So the neonatal standards of care are quite, they're quite simple, they're quite straightforward. And what we normally require first and foremost is a clean environment. That is basically, if you have a clean environment, basically everything else is taken care of. And very important, which you're going to see in subsequent slides, ability to maintain temperature at all times. There's an actual temperature you're supposed to maintain within the delivery room, and this prevents certain complications in the newborn, as we're going to see. And the staff and carers have got to have good hand hygiene. It's important because during this COVID period, we have been taught and retaught and about how to practice good hand hygiene. And this has actually impacted positively on the care of newborns at delivery. We're also going to talk about provision of appropriate nutrition. This is the promotion of exclusive breastfeeding as according to our national guidelines. We're also going to talk about the importance of vitamin K, tetracycline eye ointment for eye care, and chlorhexidine ointment for umbilical cord care. We're also going to talk about delayed cord clamping, and very important is the inclusion of the mother as a partner in the care of her newborn. So I put this picture up to familiarize ourselves with how our delivery rooms usually look like. As you can see, we have a delivery couch. It doesn't have a patient at the present, but you can see there's a delivery couch. There's some semblance of privacy here because there's a screen on the opposite bed. There's a resuscitator with a radiant warmer. There's actually an oxygen cylinder present there, just at least to provide oxygen is required. There is a safety box for disposal of sharps. There is a tray there for placement of instruments and equipment if necessary. So ideally, this should be how a delivery room should be prepared. And I got this picture from Mbagathi County Hospital. That is one of our county hospitals in this country. So ideally, as you can see, even from the monitor there, the temperature is at 22.7 degrees. That's an appropriate temperature awaiting delivery of a newborn. So I'm going to talk about the hygiene and warmth aspect at delivery. So for the hygiene part, we need to have hand hygiene of attendants. Soap and water should be available, plus the alcohol hand rub. Either or can be used, but preferably you should have soap and water and alcohol hand rub. We need to ensure a clean surface for delivery. That is making sure that after every delivery, after every reception of a baby, you need to decontaminate, you need to clean, and you need to disinfect the surface with 0.5% chlorine. Fortunately, most of these disinfectants are available in our facilities. There's also a sterile instrument. There should also be a sterile instrument to cut the baby's cord, clamp, or a cord tie to tie the cord. And in some facilities, you find that the sterile instrument is connected to the cord clamp, which actually helps a lot to maintain hygiene when it comes to cord care. And then finally, a clean cloth to wrap the baby and the mother. It is important to remember that once you use the clean cloth to wipe the baby, you need another clean cloth to wrap the baby with to maintain warmth. And as you can see on the opposite slide, A warm delivery room is also important. The baby should be immediately dried after delivery. The resuscitation area should be warm. And if this baby is being transported from one room to another, for example, if the baby is being transported from the delivery room to a newborn unit, ensure that the transportation is warm. Sometimes even apart from doing the skin to skin, we actually have incubators transporting the baby from one area to another. And then skin to skin contact between the mother and the baby is also very important in maintaining the warm chain. So this slide I've put up is to show you how babies lose warmth at delivery. It was one of the questions that were asked when you were joining this meeting. As you can see, if you place the baby on a there are also currents of air that are moving around in the delivery room. So if that happens, if there are cold currents moving in the delivery room, you'll find that the baby will lose heat via convection. And of course, water droplets also evaporate from the baby surface. Remember, the baby has come from an area where it was warm and has moved to a cold environment. So the child can also lose heat via evaporation, and heat can also radiate from the neonate out into the environment, and in this case also cause loss of heat. So remember that newborn babies are fluid covered and they lose heat through all these ways that we have talked about: evaporation, convection, conduction, and radiation. So if a baby gets cold, the surfactant production will switch off. So what does that mean for our baby? It will make it very difficult for the baby to breathe. Surfactant is important for the baby to start breathing, to start respiration, and to sustain respiration. So if this does not happen, then you have a situation where the baby actually requires extra oxygen, and in this case, oxygen supplementation. And that is why the oxygen cylinder is necessary during delivery. It also increases energy or glucose requirements. So you find that this was a baby who was born maybe stable or seemingly stable, but in a few minutes or in a few hours, the child just deteriorates. The neonate just deteriorates. So you're wondering why? This may be because the baby has lost energy, requires extra glucose, and this is because of exposure to cold temperatures. So as much as possible, let us try to maintain the warm chain upon delivery of the baby. So we must keep the babies warm and dry in the environment that they were used to when they were in utero. So what do we do after delivery? So after delivery, again, hygiene must be maintained, plus warmth. It is very easy, as we will see in slides that will come subsequently, that it is very easy for these babies to actually get infections via their skin. Transmission of infections occurs very easily in these neonates, and hygiene should be maintained as much as possible. So what do? We wash our hands before handling the babies, and if you're in a newborn unit, hand washing before handling any baby. If you move from one baby to the next, ideally wash your hands, and if that is not possible, then you can always sanitize your hands. Exclusive breastfeeding should be encouraged. Keep the cord clean. Apply 4% chlorhexidine to the cord daily. Fortunately, these medications are available in our facilities. Use a clean cloth as a diaper, stroke napkin. What we encourage the mothers here is to change the diapers or the napkins as frequently as possible. And also encourage the mothers to wash their hands after changing the diapers, because in this case, the stool is not sterile, and this can actually, if at all there's an infection, this can also transmit infection to the baby. So in terms of warmth, breastfeeding also promotes warmth. Bathing can be postponed by at least 24 hours. We do not have to wash the babies immediately after they are born, contrary to maybe some practices in other facilities. We only need to wipe the baby, keep the baby warm for at least 24 hours, and then dress the baby appropriately, provide proper bedding, Ideally, mother and baby should be roomed in together unless the circumstances dictate that both be separated, and training and awareness on unnecessary exposure. So unfortunately, some of these mothers, maybe being first-time mothers, may be unaware of what they're supposed to do with a newborn. And it is up to us as health workers to train them to promote awareness on warmth and hygiene after delivery. So for eye care, the eyes should be cleaned immediately after birth from the medial to the lateral side with swabs soaked in sterile water, and you should use separate swabs for each eye. Give tetracycline eye ointment within 1 hour after birth, within 1 hour of birth. And I would like to emphasize that the health workers should be completely certain of the drug that they're giving. Tetracycline eye ointment sometimes can resemble some tubes. For example, initially chlorhexidine ointment would resemble tetracycline eye ointment. There was that brand. The packaging of the brands was similar, almost similar, but that was eventually changed because of the accidents that happened. But it is also important, before you administer a drug, make sure that you're actually giving tetracycline eye ointment. And for the cord, if the baby is stable and active, clamp the cord 1 minute after delivery and keep the cord clean, and apply 4% chlorhexidine to the cord daily. So clamping the cord 1 minute after delivery usually ensures that at least, what do we call it? Yes, we will discuss that later. So chlorhexidine for cord care. For hospital births, for gestational weights, for gestation for more than 28 weeks or a birth weight more than 1 kilo, apply the 4% active chlorhexidine to the umbilical cord. This should happen immediately after birth and daily thereafter till the cord separates. I know there have been instances where mothers have been complaining that the cords are taking longer and longer to separate. But as long as the cord has not separated, the chlorhexidine ointment application should continue. The reason I've put up the 2 pictures is so that you can compare that one is pink in color. It may be other colors depending on the company that is branding it. Tetracycline eye ointment here is blue. So the formulations for chlorhexidine can be either gel, powder, or solution formulations. So if at all you're in a facility where the formulation is slightly different from what you have been using, then it's good at least to confirm from the packaging whether this is actually the chlorhexidine that is supposed to be used for cord care. And a concentration of about 7.1% delivers 4% of the active drug. So vitamin K is also very important upon delivery. The main importance of vitamin K is to prevent what we call hemorrhagic disease of the newborn. So hemorrhagic disease of the newborn is something that causes severe hemorrhage and death secondary to vitamin K deficiency. The image that you can see on your screen is actually a bleed that occurred in a neonate. The white part, that's a bleed that occurred in a neonate, and this was due to vitamin K deficiency. So sometimes, I know because of stockouts, sometimes vitamin K is not available, but there are instances we have had that the cords were actually bleeding after birth. So if at all vitamin K is available, the policy is to give. And it should be 1 milligram for babies more than 1.5 kilos and 0.5 milligrams if the weight is less than 1.5 kgs. So in summary, all newborns should have access to a clean, warm environment during and after delivery. Hand washing is essential, and all newborns should get vitamin K, eye care, and cord care. So this is what normally happens in routine delivery, but it's important to also note that some things may go wrong. We expect the best, but we prepare for the worst. So that brings us to the next session of our presentation, which is now neonatal resuscitation. So again, I put up the picture of a delivery room to assess preparedness of our delivery rooms for resuscitation. The best place to do resuscitation is usually on the resuscitator. As soon as the baby is delivered, move the baby to a resuscitator and do your resuscitation. As you can see, there are 2 oxygen cylinders that are right next to the resuscitator, just in case oxygen is required. So the requirements for resuscitation, as you can see, there are gloves, there are towels, there are 2 warm towels just below the stethoscope. There is also an oxygen, a bag with the oxygen tubings. There is also the oxygen, a pulse oximeter, as you can see. There's also a stethoscope, but ideally you do not need a stethoscope. You can use the wall clock and actually count, as you look at the wall clock, you can count the number of the rate, the heartbeat, as long as you're looking at the wall clock. So if this is appropriately done, as long as you're ready, just like a scout, you need to be prepared. Be prepared, because if you're not prepared, the running around actually uses up time that you would have used for resuscitation. So ideally, be prepared for resuscitation even before the delivery is done. So how do we prepare for newborn resuscitation? Hand hygiene, again, hand hygiene. We need to emphasize on hand hygiene. We need a warm environment. As you have seen, our resuscitators usually have an overhead warmer. We need warm, dry towels, a firm, stable surface and lighting, a bag, valve, mask device. In the previous slide, I know you have seen that. That's the bag, valve and mask device, which is not damaged. To make sure the valves are not damaged, we need a wide bore sucker. And I've put the oxygen in quotes because room air is adequate for immediate resuscitation. So if at all you do not have an oxygen cylinder or for any reason the oxygen has run out, make sure that you start the resuscitation even without the oxygen. And we need a clock because the APGAR score is done at 1 minute, at 5 minutes, and at 10 minutes. So we need to know how long are we going to proceed with this resuscitation. So I had put up this baby. This is a baby that was delivered in one of our facilities. And I wanted to show you the complications of the neonate at birth. As you can see, this is a floppy baby, a very, very floppy baby. The color is also not good. The child does not seem to be active or awake or alert. The posturing is also wrong, which we normally call floppy. So immediately after delivery, this is a baby who requires resuscitation. This is how they normally look like. So as you can see, 80 to 90% of our babies normally do not require resuscitation, which is a good thing because, as we're saying, we want to make sure that our neonatal mortality rate is as low as possible. But out of that, there is this 10 to 20% who might need some form of assistance. And what kind of assistance is this? You might need the 8 to 10% will need drying and they'll need warmth. So just a stimulation of the baby will actually make the baby improve and they will move up to our 80 and 90%. 3 to 6% will require bag and mask ventilation. So we expect the best, but we prepare for the worst. So these 3 to 6% are the ones we are preparing for. And even less than that, less than 1% will require chest compressions and medication. So I would like you to note that 80 to 90% do not require resuscitation at birth. So this is the resuscitation that is normally carried out when there is no meconium. So what do? We dry and stimulate the baby. So is there a cry? Is the baby breathing? Is there activity? So if yes, give the baby to the mother for skin to skin and initiate breastfeeding. But what if there is no cry, no breathing, and no activity? You position and check the airway. Clear the airway if required and check breathing. So these are our A, B, and C's that we are conducting. So this is how we position the airway. This is called a neutral position. The nose and the mouth should be parallel to the surface that you're using for resuscitation. It's called a neutral position. If the airway is clear and everything, the positioning is correct, check your breathing. So if B is not okay, this is the time at which you call for help. So call for help because you might require help during resuscitation. Initiate ventilation and continue ventilation at 30 breaths per minute for 60 seconds. So this person that you had called for help for should actually be feeling for the heart rate. So I normally say that use a 3-syllable word to make sure that you're doing the ventilation correctly. So a 3-syllable word is something like moranga. Moranga 1, moranga 2. That is how slow or fast you're breathing. Your ventilation should be moranga 1, moranga 2, like that. So this 30 breaths should be for 60 seconds as the second person feels for the heart rate. So how do you ventilate with a bag and mask? So you place the bag valve mask device on to cover the nose and the mouth, but it should not go below the chin and it should not cover the eyes. So put the head in neutral position as discussed, position the mask on the face, and provide a firm seal between the mask and the face. Make sure you do not touch the soft tissues on the jaw. Squeeze the bag to produce a gentle movement of the chest and do not overventilate. It should be as gentle as possible. The CE grip means over the mask, your thumb and your index finger should be over the mask, and your 3 fingers should touch the bony prominences of the jaw. That is the C and E grip. So initiate and continue ventilation at 30 minutes for 30 breaths per minute for 60 seconds, making sure the chest is rising. Feel for the heart rate, and if the heart rate is more than 60 per minute, continue ventilation for 1 minute and reassess your ABCs, just as we've done before. So initiate and continue ventilation at 30 breaths per minute for 60 seconds, making sure that your chest is rising as you feel for the heart rate. So the other scenario was if your heart rate is more than 60, continue with your ventilation. If it is less than 60, now this is when the second person comes in. And why are they coming in? Because they're giving 3 chest compressions for every 1 breath that is being given. So the chest compressions are actually rapid as compared to the breaths, because 1, 2, 3, then 1 breath. And if this is done for 1 minute, that should be about 90 compressions. Reassess your ABC afterwards. So this is how the compressions should be done. If you're alone, then the picture on the left applies. If you're 2 people, the picture on the right applies. So it should be 1 finger breath, just 1 finger breath below the nipple line and 1/3 the depth of the chest. So if you're 1 person, use the technique on the left. 2-person resuscitation, use the technique on the right. So what about meconium? This was one of the questions that was asked when you were joining the meeting. If the baby has never taken a grasp or cried, then check the airway before drying and suction the oropharynx to where you can see. That is very important, where you can see. The reason for this is because you don't want to worsen the situation by suctioning what you cannot see. There are other complications that are expected. And then dry the baby. So it is always suction to where you can see and then dry the baby. If the baby has already cried, then you do not need to suction the airways unless there's something in the airway. So in this case, routine suction of the lower airway is not recommended. You may have a baby born via meconium stained liquor, but is already crying and wailing. So that one, you do not need to do anything. But if you can see something, then go ahead and try and remove whatever you can see. If there's no meconium, then the first action is to dry the baby. But if there is meconium and the baby has not cried or taken a breath, then the first action is to suction the baby. So what about oxygen during resuscitation? So the question is, why is oxygen not required in the first few minutes? So immediate resuscitation with oxygen can cause harm, and about a quarter of the resuscitated babies may need oxygen after 4 to 5 minutes of resuscitation. Immediately after resuscitation, you do not require oxygen. There are some harmful oxygen substrates that are produced, and you want to protect the baby's brain from further damage. So this is why immediate resuscitation with oxygen is not required. We want to prevent oxygen radicals from accumulating in the baby's brain. So that is why for the first 5 minutes, oxygen is usually not necessary. The priority is ventilation. Put in a breath in those babies' lungs. Do not stop resuscitation to look for oxygen. I will emphasize, do not stop resuscitation to look for oxygen. So drugs during newborn resuscitation are not recommended. And this is your sodium bicarbonate, your aminophylline, your hydrocortisone, or even your 50% dextrose. Those are not required. There are special cases like babies born to diabetic mothers who you need to check the random blood sugar as soon as they're born, but routine drug use is not recommended. I'd like to reiterate that the WHO recommendation is to stop resuscitation after 20 to 30 minutes. So by the time you're considering adrenaline, I'm sure 20 minutes would have passed. So even the adrenaline may not be required. It may have a role to try and improve your CPR, but it may not be exactly effective or even necessary. All you need to do is make sure your CPR is effective. Make sure your chest compressions are adequate, that they're going in a third of the chest, and make sure that your ventilations are also adequate. But usually drugs are not recommended during resuscitation. So what about after you've had a successful resuscitation? So what is the next step? Supplemental oxygen will be required here, depending on how well the baby is able to establish breathing. So again, this is it's in the newborn protocol on how on the pediatric protocol on how to check the adequacy of breathing to determine how much oxygen you will require. The child might require oxygen via nasal prongs or oxygen via a non-rebreather mask. By this time, you should have communicated the need for newborn unit admission if necessary, but a baby who has been resuscitated should be observed in the newborn unit for at least 24 hours. The baby, you should recommend appropriate feeding and fluid therapy. This is a baby who might require intravenous fluids for the first 24 hours. Or if stable, usually we start off with IV fluids and then after nasogastric tube feeding or cup feeding, depending on the requirements of the baby. Then at this point, vitamin K and tetracycline eye ointment should also be given, and appropriate cord care with chlorhexidine. So the last two bullets, the last two requirements, that can be deferred until the resuscitation is successful. So we're talking about the first 20 to 30 minutes, and thereafter give the vitamin K and TEO and start your cord care. So in summary, for this section, the first rule is be prepared. Always be prepared, because sometimes if you're running around looking for suction tubes, suction catheters, or a bag, valve, and mask device, it might delay your resuscitation. So be prepared, have your gloves ready, have your warm towels ready, have everything ready before, if you're at all, before any delivery, be prepared for any eventuality. Dry and keep the newborn warm, and then always do the correct management of airway and breathing, which will save most babies. And make sure the chest moves. There's a certain technique that needs to be practiced and practiced regularly, if at all your chest compressions will be effective. So that's the end of the second part of the presentation. I know you have a number of questions, so I would request that you defer them to the very end. So we are now at the common complications of the newborn. So what are these complications that we may expect? Because we may have delivered this baby, we may have successfully delivered or resuscitated this baby, what is the next step? What else? What next? What next after we resuscitate this baby, or in the early neonatal period, what complications do we expect or anticipate? So we'll start off with neonatal sepsis. So neonatal infection, the first thing you need to ask yourself, is it severe? Would you admit this baby? So I would like to request some of you, if you can maybe type in your responses on the chat. I'll give you 2 minutes just to write a yes or no response. So yes, yes, no. Okay, so I can see very many yes answers and a few no's. Okay, yes to admit, yes to admit, yes to admit. Yes, yes, and yes. So I would like to draw your attention to the baby on the left first. So that was one of the questions that was asked as you were coming into this meeting. Always pay attention to baby's breasts. If one looks different from the other, as you can see here, there's some discoloration on the nipple or on the right breast. It looks a bit different. It looks a bit hyperemic as compared to the other one. And then let me draw your attention to the picture on the right. As you can see, this is baby's abdomen. So there's this white area here. Then there seems to have been a blister here. And then there are these areas that look like they're healing. So most of you gave a yes answer. So let us see if that was correct. Okay, I have another question. So for this baby, to treat as an in or outpatient? Kindly respond in the chat. Inpatient, in. Good. Is there an outpatient for anyone? Inpatient, inpatient, inpatient. Okay, so most of the responses are saying inpatient for this baby. So again, I would like to draw your attention to this particular baby. Ignore the NG tube. Assume this is a baby you have just received. This was one of the babies in our unit. As you can see, the cord actually looks a bit funny. The color is all wrong. There's this area of excoriation just below the cord, and then the abdomen in itself just looks swollen. So the abdomen is swollen, very swollen. The cord looks dirty. It has a different color. And then there's an excoriation below the umbilicus. Okay. So I had another video. You can also write the responses in the chat box quickly. Let me play the video. Okay, let me play the video again. Okay, I'll play it one last time. Okay, so what problems do you see in that particular baby? Chest indrawing, difficulty in breathing, baby in respiratory distress, baby is grunting, chest indrawing, use of accessory. Yeah, very good, everyone. Very good. Respiratory distress, difficulty in breathing, scissoring of feet. Very good. Scissoring of feet, RDS, difficulty in breathing, poor position of the baby. Very good. In distress, baby with respiratory distress. Anything else? Too large a mask. Good. Difficulty in breathing. I'll play the video one more time so that you can see the problems. So you can see the cesarean that somebody mentioned. The mask is too big for the baby. The baby is actually grunting and the baby is in severe respiratory distress. So I'd like to share that. Okay, let me stop there. So in the previous group, after watching some of these videos and some of these pictures, one of the healthcare workers was actually able to identify a child in the postnatal ward with these signs and referred appropriately for management. So in these two tables, there are these signs and symptoms that indicate the need for empiric IV antibiotics, IV, i.e., treat the child as an inpatient. So we'll start off with the localized signs because that was one of the first pictures that we saw. If you have many or severe skin pustules, admit the child. If you have periumbilical flaring or redness, admit the child. Umbilicus draining pus, like in the second picture, admit the child. If you have a bulging fontanelle, same thing. Painful joints, joint swelling, reduced movement and irritability. For example, if mom complains that the baby is crying too much, that is a baby you need to assess carefully and even admit the child for further management. Always listen, always listen to a mother's concern. Even if her concerns do not seem valid, take the time to actually examine the baby because irritability is one of the signs of sepsis. In the second picture, you can also see severe abdominal distension is one of the signs of neonatal sepsis. And I would like to encourage you as you examine these babies, undress them, remove the diapers, remove the many clothes that they're usually wrapped in so that you can get an adequate assessment of your child because clothes hide very, very many things. So those are the localized signs that we can miss out on if at all you're not looking carefully for them. And then for the systemic signs, history of difficulty in feeding, history of convulsions, if you have a temperature which is high or low. So I would like to encourage you to always take the temperatures of this baby. If you find a low temperature, admit the baby for treatment of neonatal sepsis. If the child is breathing fast, a respiratory rate of more than 60, also admit the child. Again, if your child is breathing slowly, I know it is not here, but if your child is breathing slowly, this is also a baby who requires admission. Grunting, as we've seen in the video, change in the level of activity, severe lower chest wall indrawing, we have seen that in the video, and cyanosis, if at all you have access to an SpO2 machine. Remember that jaundice, prolonged capillary refill, and pallor may also be associated with infection. So, of course, when there's infection, you need antibiotics. So the good thing with our guidelines, with our pediatric protocol, is that the guidelines are there, very clear for us to use. So it was informed by best practice, organisms, antibiotic sensitivity, whether there's meningitis or not. So in a Kenyan study that was done, there were confirmed cases of both gram-negative and gram-positive organisms. I usually emphasize that if you're going to give an antibiotic, especially in the neonatal period, make sure that it is covering what we call gram-negative and gram-positive organisms. So that is why we normally combine penicillin and gentamicin or ampicillin and gentamicin. The penicillins will cover the positives, the gentamicin will cover the negatives, and ceftriaxone will cover both. So unless directed by local bacteriology. That means you have done studies and found that there are other antibiotics that are appropriate, penicillin or ampicillin if it is available, and gentamicin should be used for treatment for at least 7 days. So, is there meningitis? This is a common question. And the answer is you will never know unless you do a lumbar puncture or CSF analysis. So as you can see in this child, I wanted to demonstrate a bulging fontanelle. This is how it normally looks like. It is actually clearer in neonates. This is an older infant, but yes, this is a bulging fontanelle. And it's common. You can see 1 in 5 babies with infection had meningitis in one Kenyan study. So in our protocol, there are actually guidelines that show you how you should treat a baby you suspect to have meningitis. The days there are clear. It is not 3 days. It is not 5 days. The answers are very, very clear in the pediatric protocol. So how long should we treat? If it's severe neonatal sepsis, this is according to our protocol, the child should have had an LP, a lumbar puncture. But I know we normally do not have infrastructural support for sending our CSF samples for analysis. So ideally, if it's severe neonatal sepsis, IV/IM antibiotics should be continued for a minimum of 7 days or until completely well if the lumbar puncture was clear. If your CSF was clear, the antibiotics should continue for a minimum of 7 days. I would like to emphasize that IM are very painful. So let us not subject our children to IM antibiotics, preferably intravenous antibiotics. For neonatal meningitis or severe sepsis and an LP was not performed, the antibiotics should continue for 14 days. And if it's gram-negative meningitis, antibiotics should be continued for 3 weeks, that is 21 days. So what about antibiotic prophylaxis? We get this question a lot, that the mother had a prolonged rupture of membranes, that's for more than 18 hours, a mother had fever during labor, or you suspected or there was confirmed chorioamnionitis, the mother had a UTI or any form of sepsis at any time during labor or in the last 24 hours before and after birth, then what should be the way forward? Benzyl penicillin and gentamicin standard dose given for 48 to 72 hours. So this is 2 to 3 days. So this is usually a seemingly well child, but the mother had these particular complications. So at this particular point, you can actually give antibiotics for 48 to 72 hours. Perfectly acceptable. This is in the pediatric protocol. But if the child has any signs of sepsis, then at this particular point, then you should treat as the pediatric protocol says. So there's a question, is it right to give gentamicin for neonates? And the answer is yes. It's actually in our pediatric protocols. So the pediatric protocol I'm talking about is the Ministry of Health guidelines for the management of pediatric patients. It's actually online. You can download a copy. It is available. It is available for use for anyone. There are usually soft copies available, but if you go to the Ministry of Health guidelines or even type in pediatric protocols, Ministry of Health, you will find a copy for yourself. So neonatal jaundice, it occurs in more than 50% of normal newborns. More than 80% of preterm infants will have some form of jaundice. Jaundice may be normal or abnormal depending on the day of presentation, the gestation of the newborn. As you can see, the preterm infants are at higher risk. Severity of the level of jaundice. Of course, if the jaundice is at the level of the foot, as you can see in this particular neonate, then that is a child who requires admission and presence of associated symptoms. So remember our previous slide that said jaundice can be a manifestation of sepsis. You need to be on the lookout for sepsis in these particular neonates. So when do you treat jaundice? If it's day 1, investigate, do a hemoglobin level and a direct Coombs test. And if it's very high, you have checked your bilirubin levels and they're very high, refer for possible exchange transfusion. So the levels again, the levels at which to refer are in the pediatric protocol. Start phototherapy immediately, even if the jaundice is mild, okay? Usually by the time you're noticing jaundice, that is a child who requires phototherapy. So if it is, especially if it is on day 1, but from day 2 to day 14, investigate and treat based on the tables that are on the pediatric protocol again. So depending on the gestation, the postnatal age, and the bilirubin level. So if it's the second day and above and you're unable to measure bilirubin, you treat based on the clinical signs, i.e. if you can see jaundice, treat. Start treatment early in preterm babies. Jaundice, of course, is associated with some level of brain damage. So the treatment should be started as early as possible. And neonates with jaundice beyond 14 days should be referred for further evaluation to rule out cholestasis and hypothyroidism. So if you come across a child with jaundice past 2 weeks of life, kindly refer that child for further investigations and management. So there's a question here we are going to ask, which you're going to answer. Is it okay to give gentamicin to a preterm baby? I think I'll answer that at the end. Is it safe to give gentamicin before a neonate passes urine? I'll also answer that at the end. So the first one, is it okay to give gentamicin to a preterm baby? The answer is yes. There are certain dosages that have already been calculated to match the requirements of the preterm baby. So that one, yes, you can give. And is it safe to give gentamicin before neonate passes urine? I think I'll answer that at the very, very end. The other question that has been asked, can you give neonatal ampiclox in place of penicillin and gentamicin? And the answer is no, a resounding no. And somebody has uploaded, I think, the copy of the pediatric protocol on the chat. So thank you for that. So phototherapy depends on the distance from the lights. We recommend 30 centimeters. You can increase, by the time you're increasing the distance to 60 centimeters. So these are 2 rulers. You're decreasing the power by 50%. Also good to check the baby's temperature to avoid overheating. Do not forget to cover the eyes and do not cover with a blanket. It will be too hot for the baby. So I had another video here. Kindly share on the chat the concerns that you can see. In the video. Let me play the video again. Okay. So a weak cry, the child seems restless. The cloth is covering the baby's face. An abnormal cry, good. Irritability, very good. The abdomen is distended. The baby not fitting the cord, yes, correct. Bad position, yes. Grunting, okay. Restlessness, good. Dry skin, yes, very good. A faint cry, yes. Looks jaundiced, okay. Baby's eyes not covered. All right, I'll play the video for the last time before we move to the next part of the presentation. Okay, just a minute. Okay. Right. Okay. Oh, convulsing. Very good. Very good. So let me stop this video. Move to the next slide. So our final topic was neonatal convulsions. And how do we evaluate for a neonate with convulsions? So there's something called an ABCD evaluation. So the first thing is to check for your ABCs, the airway, the breathing, and the circulation before you move to drugs. So drugs here actually means you check for hypoglycemia first. If it is present, you treat with 2 mL per kg of 10% dextrose. So that is not normally the 50% dextrose. No, it's 10% dextrose. And then if a neonate is convulsing, you start phenobarbital. So the ideal practice is 20 milligrams per kg start. That means if a child is 3 kilos, you're going to give 60 milligrams of phenobarbital, then 10 milligrams per kg if the child is still convulsing after 20 minutes. And if after another 20 minutes, the child is still convulsing, you give another 10 milligrams per kg. But if you give the first phenobarbital dose and the child stops convulsing, then you should not give the subsequent doses. So for the antipyretics, febrile fits occur at more than 6 months. So do not say that this is a febrile convulsion if a child is convulsing. Fever can be treated for neonates, but just by removing their clothes. And if there's a fever, investigate and treat the cause. So antipyretics may have side effects, and usually it's not part of our routine medications for neonates. Use them when our simple measures are not working, i.e., uncovering the child is not working. But if the child is in pain, it should be treated. It's a separate consideration. So before I move to the summary, that particular child was actually convulsing. I wanted you to pay particular attention to the cry, because unfortunately, these are the babies we give to mothers to breastfeed, assuming that maybe the child is irritable because they're hungry. And once you put the baby to the breast, usually they are unable to breastfeed. If also you notice the cycling movements, that is why the baby was moving around on the cot. The child was having the cycling movements of both the upper and the lower limbs. That was also a sign of a convulsion. And the high-pitched sound at the end, a sign of a convulsion. So I was actually happy that one of the consultants shared a similar video with me. That was Dr. Kigondu, recognizing a convulsing child, and he immediately referred the child for further management. So in summary, neonates need rational antibiotic use for the treatment of infections. Empiric antibiotics are still effective. Always look out for neonatal meningitis. The signs are very subtle, and neonates with significant jaundice should receive effective phototherapy and/or exchange transfusion if severe, and treat neonatal convulsions by use of ABCD assessment and appropriate anticonvulsants. So now we open the chat for questions. Thank you.
Thank you, Helen, Dr. Githaiga, so much. I think I had seen a few questions earlier. Let me read some of them to you. There was a question on vitamin K. Let me scroll up. Yes, someone had asked for clohexidine. There are many complaints of unhealing cord. I think you mentioned something about that.
Yes.
You know,
So for clohexidine, I think I can respond to that. Yes, there have been complaints, but according to the guidelines, hello? Yes, so according to the guidelines, the Ministry of Health guidelines, we are supposed to use the clohexidine. Yes, there has been that complaint among many mothers, not just in the public sector, but also in other sectors as well. So yes, it has been noted, but in terms of neonatal infections, there has not been an increase in the neonatal infections as we are using clohexidine. So I think even as the cords, the delaying of the breakage of the cord is happening, clohexidine is still quite effective in the prevention of umbilical cord sepsis. Yes, thank you.
Okay, thank you for that. There's another question: is oral vitamin K as effective as IM? And then still on vitamin K, kindly repeat the dosage of vitamin K according to birth weight.
Okay. So for vitamin K, oral vitamin K, usually here is something, how quickly will it be available in the baby's body to prevent hemorrhagic disease of the newborn? So an intramuscular dose is actually a quick and rapid way of ensuring that this vitamin K is available for use immediately after birth. So if at all the baby, for example, the baby had a cannula, we would actually give it intravenously. But for the effective dose to be available as soon as possible, then that is why the children are given intramuscular vitamin K. Sometimes oral vitamin K is given when babies have other complications like late onset hemorrhagic disease of the newborn. Yes, it's actually given, but immediately after delivery, then intramuscular vitamin K is recommended. And the other question was?
The dosage.
Or the
There was a
dosage
question on the dosage.
Yes, for more than 1.5 kilo babies, for more than 1.5 kgs, the dose is 1 milligram. Fortunately, the vials are usually calibrated to 1 milligram. So 1 milligram for more than 1.5 kilos and 0.5 milligrams, which is half of that for less than 1.5 kg babies. Thank you.
Okay, there's still about 2 or 3 more questions around clohexidine. So there's one about clohexidine makes the cord wet and therefore times to heal. I see mothers being advised to use surgical spirit in the facility where I work. And I would also share my own experience with that and the recommendation from the colleagues I've worked with, pediatricians. Someone else is asking what's the alternative for clohexidine. I think maybe we can cover that as a whole, then we go through the other questions.
So what's the difference between clohexidine and surgical spirit is that clohexidine is actually an antibiotic ointment. So that in itself, it's a drug. So surgical spirit, what it does, it's just like your sanitizer. It will sanitize your hands for a few minutes and then the effect will be lost. But clohexidine in itself, being an antibiotic, is actually effective, more effective. It lasts longer, its effect lasts longer, and it's actually what is recommended by Ministry of Health. So the drying effect of surgical spirit is actually what facilitates the falling off of the cord earlier. But this other one, being a gel or an ointment or a powder, will should I say not promote falling off of the cord faster, but I will reiterate that it is very, very effective in the prevention of umbilical cord sepsis. So I know the concern is usually, how long is this cord going to take off? It's happening with even us as healthcare workers. We have such concerns that the cords are not falling off, but clohexidine is very, very effective.
Okay, I think that has been well covered. There's another question, comment about cord clamping for HIV mothers. And another question, should we give humidified or dry oxygen during resuscitation?
So, hello. Hello.
Hello.
Oh, okay,
Can hear you.
I'm all right. I'm back on. So ideally, the oxygen should actually be humidified. As you have seen, the oxygen cylinder was connected to a humidifier. So ideally, if you give dry oxygen, it's going to worsen the situation. It's going to make the mucous membranes very dry. So that means the baby is going to be breathing in dry air, which is dangerous for the baby. So ideally, a humidifier should be present, and that is present usually in the oxygen cylinders. Yeah.
Okay. And there's a question about comment about cord clamping for HIV mothers.
Now, should I answer that or should I leave that for the obstetricians?
Okay, maybe we can help each other. We recommend delayed cord clamping, except now for HIV positive mothers and babies who require immediate resuscitation, like there's obvious distress and yeah. So for a HIV positive mother, we would not recommend delayed cord clamping.
Okay, so question answered for that particular participant.
Okay, thank you. What's the calculation of intravenous fluids to the newborn, as in how much fluid is to be given in 24 hours?
Okay, so at least the goodness with the pediatric protocol is that most of these drug dosages, most of the calculations, most of the requirements are actually present. They're easily calculated for you. All you need to do is actually just refer. They are there in the pediatric protocol. I do not want to give them in this particular discussion, but they depend on the weight of the baby again. The volumes are different for term babies and they're different for preterm babies, depending on the weight of the baby and the gestation. Thank you.
Okay.
Yeah.
Thank you for that. Yes, I agree. It's not practical to give dosages for all the weights this particular moment. So do you encourage jaw thrusts and chin lift during the resuscitation?
The answer there is no. Jaw thrust and chin lift are for infants who are 1 year and above. So for the ones who are less than 1 year, it's just neutral position, because the jaw thrust and chin lift will actually close a neonate's airway as opposed to opening it up. So neutral position for a neonate until neonate and infants less than 1 year. After that, you can use the jaw thrust and the chin lift maneuver. Thank you.
Okay, then thank you so much. For the oxygen administration, what maximum oxygen can you give per liter if using nasal prongs, non-rebreather mask, or just normal mask?
Okay. So I will encourage all of you, you can get a copy again of the pediatric protocol, but for prongs, you can go as high as 2 liters. For prongs, yes, it is allowed 2 liters. That's high flow oxygen for neonates, 2 liters. And via the non-rebreather mask, because it has a reservoir back, up to 15 liters per minute is acceptable.
Okay.
Yes.
I think we'll end it there. You have addressed most of the questions. We may not be able to take all the questions because of time. And once again, we are very grateful for your time, and we look forward to future engagements with you. For the participants, we have 1 more week to go, 2 more sessions on Monday and Wednesday, and we look forward to having you all there. On Wednesday, we shall have a closing sort of virtual ceremony to award the certificates and basically to give our thanks to the people who made this possible. So I think from me, that's all. I would hand over to Lakshmi and Njoki to end the session for us.
Dr. Vinny, thank you so much, Dr. Hellen, for sparing your time for us. Indeed, a very informative session. Thank you, everyone. What we'll do is we'll check for the remaining questions and we'll share it with Dr. Hellen so that she can maybe answer it, and we'll share the responses with all of you. All right, so see you all next Monday. Wish you all a very good evening. Thank you so much.
Good evening.
Good evening, everyone. Bye.
Bye.
Thank you, Hellen.